All right, welcome everybody to day 2 of Koopmans Lecture Series. I'll just give you a few minutes to arrive. So we're talking about psychosocial oncology research and practice with Indigenous communities, unique issues and key considerations. We had a wonderful session yesterday, and we hope many of you are returning for our second day. I'll just give a minute for people to arrive here. So let me introduce myself. I'm Dr. Carlson. I'm a professor in the Department of Psychosocial Oncology at the University of Calgary. I'm head of the planning committee for the Koopmans Lecture Series. And let us begin with a land acknowledgement. We acknowledge that what we call Alberta is the traditional and ancestral territory of many peoples presently subject to Treaties 6, 7, and 8, namely the Blackfoot Confederacy, the Kainai, Piikani, and Siksika, the Cree, Dene, Saulteaux, Nakota Sioux, Stoney Nakoda, and the Tsuut'ina Nation, and the Métis people of Alberta. We acknowledge the many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. We are grateful for the traditional knowledge keepers and elders who are still with us today and those who have gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. Now, yesterday we had Jan Koopmans do an introduction to the Koopmans Lectureship, which was really nice to hear a bit of the backstory. This speaker series is supported by the Katherine Porikos Koopmans Lectureship in honor of Kathy Porikos Koopmans, who was a researcher and in obesity research and metabolic research, but also had an interest in psychosocial oncology. Unfortunately, she died young from a breast cancer diagnosis, but she wanted to see the research continue in this area. So her late husband and her mother established the Katherine Porikos Koopmans Lectureship, and that's what brings us here today. So the lectureship supports distinguished visiting speakers presenting a lecture on psychosocial oncology, and it's managed by myself through the Division of Psychosocial Oncology. So today our schedule is going to begin with BigSmoke, who is an Indigenous patient navigator with Alberta Health Services and part of the planning committee. She will be introducing our speakers and our discussant. Then we'll have our 2 speakers, Ms. Leah Bill and Dr. Rita Henderson, followed by a moderated discussion. Hopefully our moderator from Australia is going to arrive. If not, we'll figure it out as we go along, and then an audience Q&A. So please, as yesterday, if you want to put a quick note in the chat, where you're coming from, where you're joining us from, whether you're from Alberta or elsewhere across Canada or around the world. And as questions arise, as we're going through the lecture, feel free to put them in the chat box, and you can just preface your questions with a heading question to distinguish them from the comments. All right, so now I'm going to turn it over to Arrow to do the introductions of our speakers.
Our second presenter is Dr. Rita Henderson. She has a doctorate degree in anthropology. All of her research activities in some way or another seek to innovate how primary health care services and systems may be organized to better serve specific populations with a particular interest in innovating mental health and addictions models. This leads her to explore how to best forge inclusive spaces for Indigenous knowledge and healing practices within Western healthcare. Her work towards Indigenous health equality applies to a systems approach to address population health inequities, anti-racism, and structural competency education and health professional practice. She is located in family medicine and takes a generalist approach to a range of health, wellness, and disease modalities. Finally, she co-leads the Medical School's Truth and Reconciliation Commission response titled The Indigenous Health Dialogue, where her focus has been on connecting population health inequities and research into systems change and critical health professional education. Finally, we welcome Mr. Darren Nolan. Darren Nolan is a lecturer at the University of Newcastle on Indigenous Academic Health, School of Medicine, and Public Health in Newcastle, Australia.
Excellent, thank you. Once again, very accomplished speakers we're about to hear from. So we're going to turn it over now to Dr. Henderson, and I think you're going to share your own slides, so I'll let you go right into it.
Can you see them?
Yeah, you just need to bring them up to, yeah, there you go.
Okay. You can hear me okay?
Yep.
Thank you. So an honor to join you today and to have been invited to present next to Leah Bill and after Angeline Latondra and Yael McGarvey, because of really being a non-Indigenous researcher from who grew up in Southern Alberta in Treaty 7 territory. I feel very humbled to share some of the learnings that that I've made over the years. I've deliberately maybe titled this presentation a little bit edgy with the title like Shifting White Systems for Indigenous Health Equity, but my purpose here is really to position myself as a non-Indigenous researcher looking at how non-Indigenous systems can be more suitable, more safe, more appropriate and accommodating and effective for and with Indigenous peoples. And so I mean, I could say settler systems or what have you. I will speak a little bit about the colonial legacy that we have. Our research team certainly affirms exists within Western healthcare systems, but I don't mean to use the term like white as too disruptive or to only kind of cast our healthcare as inequitable, but I do want to highlight the knowledge systems that inform the type of medicine and care that is provided generally within our healthcare systems in Alberta and Canada more broadly. Just a second. Here. I'm a models of care scientist in the departments of family medicine and community health sciences, but I'm actually trained in the social sciences. So I'm not myself a practitioner of healthcare. I come to this work as a scholar, as somebody that is invited by these departments and by people in healthcare to explore how health services are delivered, to ask big questions about whether what is delivered is the most appropriate, and to innovate those services with particular people and populations and communities in mind. And because of my relationships and my sort of training and mentorship by a Blackfoot physician scholar in family medicine by the name of Dr. Lindsay Croshoe, almost 90% of the work that I do happens to be in Indigenous health, and I'm very grateful for that ongoing relationship. So as a social scientist, some of the questions that I ask of my research and the various work projects and initiatives that we do are like to try to get assumptions or silences or actual interests that shape what we call successful healthcare or what we anticipate or expect of healthcare services, and to identify gaps between what we say in healthcare we're doing and what are the actual outcomes and what does that mean for the quality of care. If we're only measuring in terms of morbidity and mortality, is that the most appropriate maybe or life expectancy? Are these the only appropriate indicators that we should be following, and how else can we open our imaginations for improving care? So in speaking today, I have really one message that I want to convey, and it's coming together through a story of a number of different initiatives that we undertake in a lot of our projects. But I want to speak a little bit about how our work in Indigenous health synthesizes the evidence base, often because as Leah Bill was just highlighting, that we're dealing with very different knowledge systems and very different, often seemingly in competition knowledge systems that seem not sometimes to be able to talk to one another and be more integrated. And I take as guidance from my mentor, Dr. Croshoe, that seeming separation of Indigenous and Western knowledge around health and wellness it can be quite artificial. And so I want to highlight through a number of our projects how our team sees the possibilities for more of a rapprochement and a coming together of knowledge systems at least for what that means in terms of providing more safe and appropriate clinical care. And I give this message, or I bring this message through an argument that Indigenous health is itself a unique discipline within healthcare and within medicine. Often we see researchers that work in Indigenous health located at the margins of different fields. You know, there's like a nursing scholar that does Indigenous health research, or there's somebody in obstetrics or in family medicine that is among a set of peers that also have other sort of concentration areas that their research focuses on. And it advocating to recognize Indigenous health as its own discipline. Part of the messaging is that I'm threading throughout today is highlighting the need to actually fund and invest in the knowledge systems that and the acquired knowledge that researchers and practitioners and policy and decision makers share. Because in sharing this knowledge, we can be more systematic and more consistent in the type of system and services that can be provided. So I use this visual just to highlight how for people in Western research systems, how a lot of this work cross-cuts these silos of research and practice and education and leadership. So I speak a little bit about population health and epidemiology, but I also speak about medical education and health service planning and even the principles that are needed that undergird the type of leadership that is required. So I'll speak about a number of initiatives, but I want to start research initiatives, but I want to start by anchoring a lot of this presentation to the Educating for Equity initiative, which is truly more than a decade of work by my mentor, Dr. Croshu, who is also from Southern Alberta, Blackfoot physician scholar, as I mentioned, who in like about 2008, 2009, partnered with Maori and Australian Indigenous scholars to explore on an international initiative to explore how through health professional education, we might better achieve Indigenous health equity. And the large initiative focused specifically on education around diabetes care, but really in taking a kind of the disease entity of diabetes, the Educating for Equity initiative just wanted to be able to have a health entity that we could connect to patients and communities about, but that had social drivers that actually shape a number of other health entities and outcomes in Indigenous populations. It's just diabetes has happened to be one that we could maybe find less triggering, less devastating in the lives of, even though it can be quite devastating in the lives of Indigenous people, but to access some knowledge, to understand some of the population-based experiences of health and wellness and the drivers of disease. So I share this slide just to highlight the complexity of knowledge synthesis that is embedded in this initiative that we've since used to apply to clinical practice guidelines and to other disease entities. We've now applied it since to obesity care, and now we're exploring how to apply it to dementia care. And I would propose that, or I pose that it has strong possibilities. It's a knowledge base that has a sort of superstructure of thinking about clinical practice with Indigenous patients that and communities that could apply well to cancer care as well. And so the big challenge, especially in developing sort of clinical practice guidelines for providing care with patients of Indigenous background and experience, is that there's often not these very large randomized control trials, like Dr. Leah Bill was just highlighting how, like, what gets constituted, what gets considered sort of legitimate medical evidence is often undermines Indigenous knowledge. And because from a knowledge synthesis perspective, I'm speaking about doing systematic and scoping reviews, what gets determined as a sort of more rigorous evidence is often from randomized control trials, which are very large studies that usually require some form of containing of variables and in order to compare intervention versus non-intervention populations. And that's just very difficult to achieve in sometimes contexts where you have very few people participating in research. And so we conducted, or we set out to conduct an RCT study as part of the Educating for Equity initiative by building up a knowledge base. We looked at literatures, we did much qualitative interviews. We did focus groups with patients from 5 communities across Canada, and interviewed more than 30 practitioners that focus, like healthcare providers, doctors specifically, that focus specifically with Indigenous patients and providing care in diabetes. And we did descriptive analysis. I'll share a little bit of the descriptive details. But then we through a consensus building process of our core team, developed a care framework, and I'll share that as well. But then the care framework informed a curriculum that we developed. And when we delivered that curriculum to healthcare providers, we then looked at the patient charts, Indigenous patient charts, a year before and following the educational intervention, to see at an RCT level, at a large randomized controlled trial level, whether we could see evidence of impact, how health professional education could change healthcare outcomes. And we do have published research in that area. I won't speak about it as much today, but just trying to highlight how challenging it is for those of us working in Indigenous health research to find ways to align the evidence both with Indigenous knowledge and with sort of westernized values about what is the evidence base. And it doesn't mean that we're always putting Indigenous knowledge to the test of Western systems, but we also try to engage the complexity of that knowledge to shift the systems in ways that will work for patients and will lead to improved outcomes. One of the important pieces that came from that work is a qualitative paper, actually, that we published in the Canadian Medical Association Journal, so CMAJ, in 2017. And I'd say that the biggest takeaway from this about healthcare experiences of Indigenous patients with type 2 diabetes in Canada is that we established through that analysis that colonization is a primary driver of diabetes experiences among Indigenous people. And this is groups of people that are urban and rural, and that were located in British Columbia, Alberta, and southern and northern Ontario, and that there is a colonial legacy in healthcare. And this is something that even I still today deal with editors that question this sort of claim that there's a colonial legacy in healthcare. But from an experience perspective, from people that we've listened to, there's a degree of power and authority that is often exerted by a healthcare provider, that the knowledge is assumed to be contained within the person that's an expert within the healthcare system. And I think Leah really highlighted the importance of positioning oneself as a helper, and seeing the traditional medicine approach is much more about not interfering with a person's path and to wellness, or their learning and the teachings that they will acquire through their experience of disease or unwellness. And one of the findings that we also learned in that work was just we were deliberate in asking Indigenous patients what were examples of good experiences of healthcare that they liked. And importantly, I think that it was often the description of young physicians new to practice that would say something like, I don't know what it's like to be an Indigenous person with diabetes. Can you help teach me? Can you help me walk this path with you? And so really a humility, learning together, and the bringing together of knowledge systems, instead of just focusing on the kind of an idea, like a distanced idea of traditional medicine, is somehow like assuming that it's still a molecule, that it's somehow in a plant, or that it's in some sort of tea that a person consumes, and not through the whole relationship that a provider can have with a patient. And so in hearing, we contrasted what we heard from patients with physicians, and we've published about the physicians' perspectives. And we recognize that, just like Leah Bill was also just saying, that like the physicians often focus on the origin of disease in very specific and limited terms, in terms of like the genetic driver of a cancer, a tumor, instead of seeing like the life experiences, the stressors, the wider story of a person that may lead to their experience of disease. So the care framework that we came to, and it was through this consensus process, and I won't go too much into detail, but there's this instruction that the Educating for Equity framework gives, tries to provide to healthcare providers, share. And I'll just highlight how the instruction here is embedded in this sort of, I don't know if anybody remembers these balls from like the 70s and 80s that were blue and red, that I don't know if they're racket balls or what they would be called, but we sort of built this, we visualized the framework as this idea of serve and return. What's really important is that in the therapeutic relationship is the forging of a relationship, that it becomes longitudinal, that a person feels safe coming back, that there's no one like prescriptive instruction for how to provide care to Indigenous patients. Like there's no like, you know, sometimes if you get a list of advice, it's not that you don't look at somebody in the eyes or something like that, but it's rather about how do you forge a relationship. And there's the recognition that there are two forces at play in this scenario. You have colonization as a deep driver of poor health outcomes among Indigenous patients, and we found that in the qualitative work, but we also linked to it in larger studies across disease entities, and how culture, if plugged into well, can be protective of health and can be restorative of health. And then so that the red and the blue there in that visualization, and we instruct physicians or providers to try to tap into two areas as they think through how to guide someone. And one is recentering the relationship, trying to dismantle power and authority, and also engaging in the social reality of a patient and a community. And so the clinical practice guidelines, the EFRI care framework is published in the clinical practice guidelines for providing care to Indigenous patients. And so that's in the Canadian Journal of Diabetes, but the care framework is more elaborated on in an article in the Canadian Journal of Family Physicians. We then also adapted this to this knowledge base to obesity clinical practice guidelines that were published, I believe, last year. Again, I'm just highlighting the role of needing to innovate evidence synthesis to ensure that it's not that we don't agree with things like what Leah Bill is highlighting is the difficulty of having Indigenous knowledge be recognized and supported on its own terms within medicine. But we're also trying to frame this knowledge in ways that non-traditional consumers will actually get it and use it and be informed by it and integrate it into their practice. And so, we recognize that with obesity in contrast to diabetes, this is not itself necessarily a disease, but it can drive many poor health outcomes, and addressing obesity can be a means of promoting health. And so we did evidence synthesis, but we recognized we had to hear from people. And so we actually convened a sequential focus group of individuals, and the map there kind of highlights the geographic and cultural dispersion of the origins of those who participated. And they all came together in Calgary, and over a period of time informed, like we were bringing information from the literature that was largely not clinical in nature, but largely population health in nature, things like doing recommendations that to address obesity in Indigenous populations, encourage people to reconnect to the land, to engage in community gardens and so forth. But in connecting to a group of people in an urban base, because we were just limited to who we could connect with, we also had heard stories about how like reconnecting to land is something of a very politicized nature. Not everybody has access, and both to knowledge or to place, and some of the stressors that come with that and may render one more vulnerable. So we came up with different recommendations than our care framework. But again, this is something I think that also connects well with cancer, the area of cancer, which is about validating patient experiences, recognizing the role of stress and systemic disadvantage in health outcomes. And one of the areas that was of particular interest to the group of people we spoke with was this idea of resistance to care, to Western healthcare, or a seeming apathy or paralysis that sometimes we recognize that both patients, people in community, and providers can express in terms of navigating a therapeutic relationship. And we really highlighted that we resisted terms like patient noncompliance, or we try to shift the language away from talking about patient resistance to Western models of care, but really highlighting how we're trying to promote a concordance between Western and perspectives and indigenous perspectives, and through that concordance trying to rebuild trust, recenter trust, and help both patients and providers and communities feel that there is something therapeutic that can be walked together, and not simply sort of expect one size fits all kinds of care. And this requires building complex knowledge together to heal relationship, and understanding how patients particularly, but communities more broadly, may want to access knowledge. And they don't always want to access it from a physician. What context does knowledge get shared in, and how? And to do so in a way that is concordant with the patient's priorities and perspectives. Lastly, I came to work with Leah Bill and Angeline Latondra on the Avina project several years ago, and we've published from that. I'm just putting this out there for anybody interested in understanding our work around the promotion of HPV vaccination in First Nations boys and girls. It was a very large team of very brilliant people that highlights the abilities to do complex research, but also immense amounts of challenge that come with trying to do so in an ethical way, and in doing things at a pace that is appropriate and concordant for community priorities. And this is published in Gynecologic Oncology, I believe, in 2018. And these were just 2 of 3 objectives that we were very interested in. But thinking about vaccination, how can you promote vaccination in a way that doesn't just sort of assume that everybody will feel safe with it? Public health in particular has a colonial legacy in Canada that often in Indigenous communities, public health is sort of like the only experience of healthcare that in far remote areas, and understanding those barriers and support to vaccination. And the initiative grew from research that I highlight from Leah Bill's team at the Alberta First Nations Information Governance Center. I don't know if many people in this audience would know that the AFNIGC publishes these excellent health trends that highlight health disparities and inequities. They're one-pagers, much like Alberta Health does, but they're a great resource for at least recognizing health disparities, but they certainly don't, as epidemiological studies, they don't give us much direction clinically. And so that initiative was inspired by these types of kind of large scale or epidemiological studies that show differential outcomes, differential screening, despite disparities in infection rates. And the work, I think, really highlights the importance of working together with knowledge holders and community partners because of the high risk of stigma that can be perpetuated, and the need to ensure that those people most affected by the care are actually in the driver's seat and determining the direction of research. So this is a table from that work, and I won't linger too long, but I want to return to the argument I made at the outset that Indigenous health is a unique discipline, because I think that's where, if we're thinking about shifting white systems or Western medical systems, we need to start recognizing that everybody working in Indigenous health, that we share a common knowledge, we have a common vision. Call 18 of the TRC really highlights this, and noting that the prior government policies towards Indigenous people, in particular around residential schools, is the primary driver of health disparities in Indigenous populations in Canada, which are genetically, culturally, geographically diverse groups of people, but nevertheless experience many of the same disparities. And so that common knowledge base, I would encourage everyone to connect with and to recognize as something significant and unique of its own, instead of not to discourage anybody from entering Indigenous health research, but I use it as a caution as someone in the medical school, seeing that there are increasingly resources at federal levels to be able to access to do Indigenous health research. But if we don't do it led by Indigenous peoples and their organizations and priorities, then the risk is that it becomes self-serving for Western systems. And so part of that is to create space for Indigenous leadership within systems through empowerment and the inclusion of culture as a facilitator of health in order to achieve equity. So I end with welcoming anybody to reach out. I love to connect to people on these topics. And this last image was an image gifted to the medical school from an artist by the name of Kevin Pies, who gifted it through Dr. Lindsay Crochut as part of our Truth and Reconciliation process. And please, if you're interested in doing more research in the area or connecting, also recognize that Dr. Lindsay Crochut is now the Assistant Dean of Indigenous, not affairs, but it's just an Assistant Dean Indigenous at the medical school, and is keen to grow a strategy. And he's a lead of a multi-year initiative to innovate Indigenous primary healthcare in Alberta. And so we're interested in connecting to people that are committed to this platform for achieving equity with Indigenous populations. So thank you, an honor. And I welcome questions today. And thank you again, Leah, for starting with such a great presentation.
All right, if you can just take down your slides there, Rita. That was, I know you were a little rushed. There's so much work that you've been doing that can be really useful for everybody. So we're going to turn it over to the discussion.